Did you receive
Okay.
my PowerPoint as well, just in case?
Yeah. All right. Hello, everybody. Let's turn this waiting room off. Nice to see some new faces, some old faces. For those who might not know me, my name is Jessica Steinberg. I'm one of the co-founders of entOURage, and Jasmine Thomas is also here, but not on video right now. And entOURage is a women's empowerment platform for the legal cannabis market in the UK and EU. We've been up and running since about 2018. We were just reminiscing about how nice it would be to be back together in a room. So hopefully when we are back in the UK, we can do that, but we've moved everything online since COVID. And this is a really exciting event for us. We did one in person about a year and a half ago, maybe nearly 2 years, I guess. And Jasmine and I have always felt that talking about patients, allowing patients to really share their experience and come first is so important, because that's exactly where the industry was started. That's why we're here in the first place. We all know and believe the power of research and science. So I am so excited to pass this over to Anne, who's going to kick us off with a presentation. There will be time for Q&A. So throughout the entire presentation, feel free to either, you can message me directly or you can write it in the chat if you have any questions, but we will also make it possible for you to just ask your question directly towards the end. Any question is a good question, so please fire away. I'm sure she has great answers as well. So I am going to make her a host so she can share the screen, and then we'll begin with a presentation. And if everyone who is also just watching, if you can remain on mute, that would be great, so that everyone can enjoy Anne's presentation as best as possible.
Right, let me get into slideshow. Okay, is that okay?
Yes.
Okay,
yeah.
Great. Yes, thank you, Jess, for inviting me, and thank you for hosting. My name is Anne-Kathrin Schlag. I'm head of research of drug science. We're a UK-based charity, and medical cannabis is only one of the kind of drugs we're dealing with, so to speak. I'm going to explain a little bit more afterwards as well. And I just wanted to reiterate, I'm very happy to answer questions afterwards, and whether that's in the chat or, let me just get myself away, or live afterwards. So I'm going to speak about medical cannabis in the UK, and I'm going to present some very preliminary findings of Project 2021, our real-world evidence base, which we launched last year. I'm also going to put things in a slightly broader context, speaking of patients and patient access here in the UK, and also highlight some of the other work, research work and scientific work that we have been involved in and that we're continuing to do. So yeah, hopefully that's going to be interesting. So the outline of my presentation, I will introduce Drug Science, our charity, and then speak a little bit about the Drug Science Medical Cannabis Working Group, to give you really a rationale why we launched this group and what we're doing as well. One of the aims, obviously, is to develop the scientific evidence base on medical cannabis in various forms. And I will highlight some of our other research in addition to Project 2021, namely observational audits with patients already using medical cannabis to treat the epilepsies, and our multi-criteria decision analysis approach to assess the benefits and safety of medical cannabis for chronic neuropathic pain. And then I'm going to discuss some future developments and also open the floor for discussion if we want to have a discussion about the kind of state of medical cannabis here in the UK especially. So this is our charity Drug Science. I will have a link and a page of references which Jeff can share as well with our webpage. And Drug Science, we pride ourselves to speak the truth about drugs. Drug Science was founded by Professor David Nutt in 2010 after he was sacked as a government minister for drugs, basically from the ACMD, the Advisory Committee about the misuse of drugs. He was sacked because we basically told the government about the dangers of alcohol on one side and also highlighted that drugs such as psilocybin, cannabis, and also MDMA are not necessarily as harmful as their scheduling lets people believe. So really aim to tell the truth about drugs without political interference. Our vision is to see a world where drug control is rational and evidence-based, where drug use is better informed and people who use drugs are understood and not stigmatized, and where drugs are used to heal, not harm. So obviously also very relevant to cannabis, what we're discussing today. Our mission is to conduct and promote drug science so that public knowledge can be based on reason and evidence rather than, political and media sensationalism. And just to highlight here, so we do obviously research, one a major thing. We have Project T21 here, where patients can also look at and register through the webpage. We have resources. Resources, we do obviously events, at the moment virtually, but later again face-to-face. We host quite a lot of webinars, podcasts, as well as educational resources, especially medical cannabis, where we have developed, for example, slide decks for medical students to be shared within universities, for doctors, and so on. And in terms of the medical cannabis education, I should also highlight that we're working together with Professor Mike Barnes and the Medical Cannabis Clinician Society here in the UK. We have loads of drug info pages, cannabis, and pretty much any drugs you can think of. If you do check our page and you notice there are some drugs missing that you would like to have included, please email us. We're always happy to add more. And then importantly, here our working groups. The medical cannabis working group, which I'm going to speak about. We also have the medical psychedelics working group, which was just launched last year, and just being launched this year is the supervised injection facilities working group. So yeah, lots of exciting research going on. And please do check our website or also sign up as a supporter. And the Drug Science Medical Cannabis Working Group. So who are we? We're a consortium of medical cannabis experts, and this includes scientists, policymakers, patient representatives, and industry partners. So really a high level of expertise across the board, from the cannabis field, pain specialists, and so on. And policymakers, again, I should also say that's across the board. We're not with any particular political party, but we have from Labour as well as Conservatives, as well as the Green Party and Lib Dems involved. So why are we doing this? Most of you will probably know that medical cannabis was legalized in the UK on the 1st of November 2018. Which led patients to believe that medical cannabis would be accessible on the NHS, easily accessible. However, this obviously hasn't happened. So about half a year or just early 2019, we formed the group to really look into what are the barriers to that, what's happening, what is stopping the development of medical cannabis, and most importantly, obviously, what's stopping the access for patients to medical cannabis, and how can we work towards it? How can we improve the situation here in the UK? And how we're doing this, we're working together. We've got an excellent team here. Everything I'm presenting here is obviously teamwork from an outstanding team of experts working together and presenting scientific evidence on medical cannabis. And with this kind of scientific evidence on medical cannabis, I don't only mean the randomized controlled trial evidence, RCTs, of which many of you will be aware that, of course, they are a little bit in short supply for certain conditions which can be treated with medical cannabis. So we're taking a broader view in terms of the scientific evidence, incorporating other data sources, developing large-scale data sets such as T21 and so on, because as you know, cannabis is not that easily studied with only RCTs. I wanted to give just a brief background before moving on to T21 on our recent research. A reason for that is because it's very recent, it's very exciting, and we've got Abbie Hughes in the panel, who was instrumental in helping to conduct the first piece of here, as well as Hannah Deacon and entOURage, who we've been working together for second paper here. All of these papers are open access. Jess has a slide, which is very welcome to share if anybody's interested. So we make them open access on purpose, really, so that people can have easy access to it, and then that they're not behind a paywall, and so that they can also be shared and that the knowledge can be spread, really. The first paper, the multi-criteria, this one here, the multi-criteria decision analysis comparing the pharmacotherapy for chronic neuropathic pain, including cannabinoids and cannabis-based medical products, was published just a couple of weeks ago, well received. Obviously, it is fairly controversial in terms of conducting multi-criteria decision analysis on cannabis and cannabis-based products, which tended to compare very favorable in relationship to other pain medications currently licensed and currently in use. One of the reasons they came out on top, really, the cannabis products in comparison to, say, various opiate-based products, was not only because they are helpful to treat pain, but so were several other more licensed products, but also because the benefit-safety balance of cannabinoids was much better than the benefit-safety balance for various other opiate-based and strong, in a way, medications, where people generally felt that they had very detrimental side effects, which was less the case with the cannabis product. So that was really interesting. And patients also felt that generally they tended to be able to have a better quality of life whilst using cannabis-based medical products than using the opioid-based pain medications. So absolutely, interesting finding, especially if you are following the pain literature, and so many kind of controversial research is coming out at the moment, or contradictory research. So very interesting. Happy. Do please check the paper as well. The second paper I just wanted to mention briefly was together with the charity entOURage, and working together with the families and the children with severe refractory epilepsy. We conducted an audit of the impact of medical cannabis on 10 patients. So we used data that had already been established, that had been documented by parents, carers, as well as their medical professions, and really analyzed it. In many ways, the proper statistical analysis wasn't even necessary because the findings were so strong in terms of the seizure reduction as a result of using particular medical cannabis products. So again, we have now widened this paper. There's a second paper coming out with 25 patients, which is pretty much replicating these findings. I mean, extreme seizure reductions of most of these children. So very, very interesting and very important findings, we think. And just wanted to highlight also in this, additionally to this, we did a bit of a qualitative study interviewing the parents and carers of these children to really also look behind what it means when they say, okay, there's a seizure reduction. Of course, that's incredibly positive for their lives and for the family lives, but looking behind it, what it means for their quality of life, what children as well as the families are able to do, then how can they develop cognitively, emotionally, and as well as socially. So that was really interesting to have also a bit of an in-depth analysis of what's behind all the statistical findings. Anyway, and these are several of the other papers in terms of, would kind of just to showcase some of the work we're doing. There's actually more by now as well, in terms of looking at cannabis-based medicines and cannabis dependence, because of course that's an issue that medical professions all often still are very much concerned about. And we look at cannabis-based medicines versus recreational use versus risks of dependence and so on and that. So I would highly recommend it to use that. Having said that, I want to just speak about this particular paper here, which is out in press now. It's going to be published next week. Going to be a press release as well. So the data hasn't been published. So if I can ask you not to take screenshots of pictures just for this week, it'll all be out next week anyway. That would be extremely helpful for our release next week. The importance of moving beyond RCTs is probably evident for most of you, that the perception of RCTs as the only gold standard in medicine needs to be widened in relation to medical cannabis. Cannabis is not a single product, obviously. It doesn't really lend itself very well to RCTs in order to assess its efficacy, because of course there are loads of different products, loads of different compounds, loads of different ratios, and loads of different potential conditions for which it can be used. So to conduct RCTs for all of these different combinations would be a lifetime's work. So that's why one of the main reasons we are suggesting to move beyond RCTs, especially because there are patients in the UK as well as obviously globally who have shown to be benefiting from the medicine now. So we don't.
And can I jump in really quick? We have a question that would be helpful to answer. What does RCT stand for?
Oh, sorry, randomized control trials. So randomized control, I'm so sorry, I should have said that. Randomized controlled trials are seen as the gold standard in medicine. This is usually in order to introduce a new medicine into the pharmacotherapy. They have to go through various trials, different levels, different phases, and most of them are randomized controlled trials. That means that participants don't know which are they getting the actual medication, are they getting a placebo? They're usually double blind, which means also the researcher does not know if the participant is getting the placebo or the real the substance, and so on. So the usual medications have to go through a very long process of doing that, very long and very expensive as well. So with cannabis, it is a little bit different. Obviously, it has been around for thousands of years, and there are by now thousands of patients report from the US, from Canada, and so on, of patients having been taking the medicine since years. So our aim is really, our suggestion is to include also other evidence to improve patients' access for the patients who could benefit from it now. This is not to say we shouldn't do RCTs, absolutely, they're also in relation to cannabis, but in the meantime, we can use other methodologies such as audits of patients already using the medicine, the MCDAs, or observational trials such as Project T21. So Project 2021, I'm going to go through it briefly. So we are the UK's biggest national medical cannabis real-world registry. And we developed a multi-stakeholder partnership with academia, industry, clinicians, and patients. We aim to develop the largest body of evidence for the effectiveness and tolerability of medical cannabis, and we will publish the data regardless of whether it's favorable or not. So we are not influenced by industry. Industry is giving us a grant basically to do the work. So we're anticipating that up to 20,000 patients will ultimately be able to access medical cannabis through Project 2021. The indications we are covering, which are hopefully going to be widened, but these are the ones that we are looking at the moment, is chronic pain. And I'm just highlighting here, if you're interested, this is how the particular indications are going to be assessed. Chronic pain, anxiety disorder, post-traumatic stress disorder, Tourette syndrome, multiple sclerosis, MS, and substance use disorder. as well as adult epilepsy, which we have just launched now. So these are the measures that are going to be assessed. And then there are several measures which we assess on all patients, and these include sleep quality, the quality of life, assessed by the EQ5D, and mood, assessed by the PHQ-9. And for all patients, we obviously have demographics, the diagnosis, as well as comorbid conditions, any medication or medications, and previously failed treatment, the cannabis product or cannabis products and its dosing, any adverse events, and of course the primary outcome measure for each, so how it developed. So you can see it's a very intricate and very large data scale that's being developed. We're using the software CB2 Insights, developed in Canada and used by Health Canada for their database. So quite well established, and working together with the team there to make sure we also get the highest quality data. I should say that obviously any patient data is completely anonymized, and there's no way of finding out who that is. Patient access. So we work together with various patients group, as I said, as we're supported by what was previously United Patients Alliance and now the Patient-Led Engagement for Access PLEA, the Cannabis Patient Advocacy and Support Service, CPASS, and other condition-specific charities. And I should also mention that if anybody is here working for a charity who is potentially interested in medical cannabis, or whose patients are potentially interested in medical cannabis, please feel free to contact us. We're very happy to share further information and knowledge and potentially work together if that's the right thing for both. Prerequisites, that's quite important really. When a patient wants to come and to be prescribed by through Project T21, as well as for other things, you have to have a diagnosed condition and you have to have failed 2 previous medications. So it is still, we cannot offer medical cannabis treatment as a first-line treatment, not yet anyway. So yeah, the positive thing of it is as well that the cost of medication, thanks to the involvement and the generosity really of the industry partners, is kept at maximum £150 a month. So whilst we, of course, would love to provide it free, that just wasn't feasible. But this is still a very good cost ratio compared to, what other products on the market or when received through the private sector. So just to go through it quickly, because I know I don't have too much time. So you can look through the Drug Science webpage, where if you're a patient interested in it, look through the Drug Science webpage, and there are all the details available on there. Or you can also get a referral from your clinician, or even look and book an appointment with one of our clinics. At the moment, or I shouldn't say our clinics, these are independent clinics, obviously the clinics we're working together with, and obviously sign up to be joining the T21 data collection. And yeah, it should be fairly smooth at the moment, as most places. I think it's still telemedicine, so it will be an online appointment, and then hopefully you should be able to get medical cannabis prescribed relatively quickly. And obviously what is important to us is to continue collecting the data at 3 monthly intervals. So ideally, this would be what we'd like to do. So moving on to preliminary results, already very interesting. These were from the end of February. They've already changed a little bit, but this last analysis that we completed basically. So over 8,000 people registered interest, and we have over 870 patients with clinical appointment, and 611 individual patients which have now contributed their data to T21. The majority of whom, 63.3%, were male. Average age was 39.1 years. However, the age range was really from 18 to 80. So, it's really very mixed. And I think what you can see here also quite well, it is not the very young people generally, but rather more mature people who are coming to the project so far. Primary conditions, again, very interesting. And this is the initial findings which we are publishing in our paper next week. We are expecting things to change and develop over the months, over the coming years. The most common primary conditions for which people sought treatment were pain, 57.9%, as well as anxiety disorders. These two conditions included 87.7% of the sample. So really a huge amount of people, followed by lesser case, multiple sclerosis, PTSD, subject use disorders, Tourette's, and epilepsy. So really quite. Within this, what I think is very interesting, the multi-morbidity was very common. So participants were asked whether they had been diagnosed with any other physical or mental health problems. And as you can see here from our graph, most of them actually had. The minority actually had been diagnosed only with one issue. The majority had been diagnosed with 2, 3, 4, 5, and then 6 to 9, and some even with 10 other secondary conditions. So quite an unwell sample. Most common of those were depression, back and neck problems, insomnia, stress, and anxiety. So really an unwell sample. And I would like to highlight, since we spoke about RCTs, randomized controlled trials before, with these high rates of multi-morbidity, many of these patients would have actually been excluded from formal trials, such as RCTs, because of course the preference there is to investigate a particular condition, or maximum 2, but certainly not so many, in order to get really results that are very much, that are very clear, and that can be used more easily. One another point, very important, I think, we assess the self-reported quality of life using the EQ-5D5L, which is a very well-validated and widely used measures by now. And we compared this to normative data, i.e. kind of general data from the UK household population from 2018. And you can see a huge difference in our sample. The mean was 46.8 points, and the mean UK houses was actually 85.7 points. The highest, the best imaginable, would be 100 points, which really gives you an idea how far away the patients we have seen so far are from the best imaginable health. So really the key is also improving quality of life in general, as was shown really in our other studies. And I think that will continue to be a key point in terms of using medical cannabis, looking at the quality of life of patients as well. Depression, again, was extremely high in our sample. When we used a normative sample, a kind of a general population sample, it was the German one from 2013 we could find. So the rates of depression, of high depression, which means 15 plus score, kind of here, that means high depression, I suppose, was reported by 1.3% only. So 1 in 100, yeah, not too bad. However, looking at our sample, you can just see that it was over 50% who really classified as moderately severe or even severely depressed. So absolutely, very interesting. And again, highlighting the fact that these are unwell people who are coming to see us. Sleep, again, just running very briefly. Although sleep was not one of the primary qualifying conditions, so it was not of our conditions, we noticed it had a huge impact, and it was a major thing for patients. It is a transdiagnostic component of many of the disorders being studied, including anxiety, depression, and pain. It's very much related to it. So many of our patient group experienced substantial difficulties with sleep. Loads of them, over half, reported that their sleep patterns interfered with their daily activities, much or very much even. 39.7% reported severe or very severe problems falling asleep. Over 39% experienced severe or very severe problems staying asleep, and more than a third also reported severe and very severe problems waking up too early. So all not conducive to good quality of life, really. This is just because obviously we have a bit of a female orientated conference tonight, so I just put in this new findings. This is for our data from this month actually, so just a couple of weeks ago for 862 patients. It's still remaining that that we have only a third female at the moment and more males. We have to find out really still why this is, or whether this is going to change over the period of research. And women were slightly older than the male participants in our sample so far, but again, that may change. The primary medical condition reported by women was pain, 61.5%, while anxiety disorders were reported by 23.8% of the women as a primary condition. Obviously, secondary was more than that. And smaller percentages were reported for multiple sclerosis, PTSD, and epilepsy. So it's already evident that there likely are some gender differences in these disorders, with pain and anxiety disorders the most common disorders in both women and men, but women were more likely to report a primary condition of chronic pain, while men were more likely to report anxiety disorders. So I think that's quite interesting by itself, but all of this is to be analyzed further, really. So very exciting. Prescribed products, I'm just going to give a very brief overview. Obviously, there are many, many more products. We've just categorized them for ease of presentation here into high CBD products, balanced products, and high THC products. You can see we have approximately equal prescriptions of oil versus flower. 9% were prescriptions outside T21. Our study does not suggest any limits on the prescription as such, but it's it's just to the best what the patients and prescribers consider to be the best for the patient, hopefully. You can also see as over nearly a third are consuming the high CBD oil. Balance between oil and flower is pretty much identical. And then obviously there is a preference for high THC flower. So ongoing research, so what are we going to do? So 3 months follow-up every 3 months. We have still a small sample, so we've only done one round of the 3 months follow-up completely. So it was only 64 participants, but already what we can see, which I think is very exciting and looks very promising, the self-reported health of the patients improved from a mean rating of 40.9 to 63.3 on the 100-point visual analog scale, I should say. So that's actually a 50% increase, which is, it can only be a positive thing. And that's obviously for people who are interested in it, that's highly statistically significant as well. And with a high effect size estimator indicating a large effect of prescribed cannabinoids on improved health. So again, some small sample, and we're just really looking forward to having more participants going up to coming through the follow-up data sets and so on. So we're going to continue to look at the patient-reported outcomes, which we assess at 3 monthly intervals. Should also highlight we have not had any adverse effects reported through the yellow card scheme. As you may know, this scheme is available and obviously is being used by other prescribers in terms of a serious adverse effect. That has not happened so far, and hopefully it will remain that way. Our future forthcoming papers and forthcoming work focuses on condition-specific analysis. We have just looked at and started an analysis specifically on pain. Firstly, who are the pain patients, male, women, ages, and so on, what type of pain they have. There are also a little bit, which I find interesting, some little bit qualitative analysis of the pain where patients actually could put in what kind of pain do you experience. So that's going to be interesting as well. Going to look at gender differences of course, and so on. So loads of interesting findings to come. And I would like to highlight, obviously, it's going to be longitudinal data collection and analysis over the next 2 years as a minimum. That's what we hope. And so far it's progressing well, I think. And yeah, just some conclusions and future developments. I think what's important in relation to medical cannabis that we continue to destigmatize the medicine and continue to dispel the myths. Our patient population so far comprises a huge age range, more or less from 18 to 80 years old. Their consistently high rates of comorbidity and low quality of life demonstrate just how unwell many of them are. Stereotypes of medicinal cannabis users as being 20-something healthy recreational users just looking for a legal source could really not be further from the truth. I think that's already evident from the findings we've shown now, and I expect this to be the case as well. Yet the challenges to prescribing remain. I mean, we would love to involve more doctors, more clinicians, and so on. We do, doctors are still cautious in many ways. Often doctors do lack knowledge of and training in cannabis medicines. Hence, that's why we're also working towards improving the educational support, as well as for doctors, as well as for nurses and other healthcare providers, really, because nurses are very important in administering medicines too. But really, education is the key, and we're working on that, working towards it. And clearly, more work remains to be done to improve sustainable access to medical cannabis for patients here in the UK, as well as elsewhere in Europe. So I want to thank also, of course, our T21 Scientific Oversight Board, Professor David Natyum, probably Head of Drug Science and Chair of T21 as well, is, you probably will know, Professor Mike Barnes, our clinical lead from Medical Cannabis Clinician Society, as well as especially Professor Michael Linsky, who's our Head of Data, who deals with all the amazing data we are getting, as well as all our specialist experts and prescribers. So thank you very much. Here's our drug science webpage, as well as, of course, my email and Twitter. And I look forward to any questions now. So let me stop sharing.
Thank you so much, Anne. That was incredibly informative, and it seems like there's a lot of claps going around on people's videos right now. So I'm sure, I hope you can hear it, or at least see it. I'll just read some of the questions, and as I do ask any questions, anyone else that has something in mind, please just write it in the chat box. The first question is from Zach, which is, just looking at the latest 2021 updates, why do you think there are more male patients versus female patients, and how can this disparity be addressed or potential barriers be removed?
Very good questions, and we don't know the answer yet, as I mentioned, but we're absolutely going to be working towards kind of the changing this disparity. I'm not sure whether males were just quicker being involved or so, even though I don't think that is the case, or whether that has anything to do with the conditions we have at the moment, which are going to be widened, as I say. But yeah, we are basically looking into all this now. These are the preliminary findings, but we are absolutely looking into it and moving things forward, absolutely.
And then there was a few questions and some comments throughout about the cap, about being 150 pounds per month. I guess if you can just add any insight or clarifications on that. There were some links that I think Mags put out and Callie as well.
Mm-hmm. Yeah. This is a cap for the medical cannabis prescribers. This was set, and this was, I am aware of patients obviously having hoped that it would be free or cheaper, but this is at the moment, with the current regulation and importation restrictions and what our cannabis licensed producers we are working with doing, that was basically the best that we can do at this stage.
Right. Okay. So another question is from Greg, back to the patient question. How is the actual patient by patient session dosing being tracked? And how is that being overlaid against non-responders or lower poor responders?
Sorry, what was the first one? Was how it is being tracked?
Yeah, I guess it's like the dosage and administration of that. How are you tracking each patient's dose?
They have regular updates with their prescriber. Basically that is what we're doing at this moment, but there is also the aim and what we are working to do this through a particular app. So this is currently being developed as well.
Okay. And then his follow-up is, is there anything that you guys are doing or able to track for people who respond well or don't respond well to a particular dose or medication?
As far as I'm not know, but we have people who don't respond well, tend to be back very quickly, and we have there is the option of follow-up appointments as soon as patients need to do it as well, not just a 3 months follow-up. Absolutely.
Right. Sorry, he has one question. Is there a basis for each dose, or is that?
I'm sure. Well, I'm sure there is, and I mean, they obviously. I am not a prescriber, I should say. I am a psychologist and researcher, so I don't have all the details on that. I'm happy to find out more and ask our prescribers themselves if there's interest in that. It is basically just the start low and titrate up slowly approach.
Right. Okay. And I should mention I have, like you said earlier, documents and some links and articles, and I can include your email if you're okay with that, so people can get in touch if they have follow-up questions. We do have another question from Marina. What do you think is the biggest incentive for patients to participate in the program?
Well, I would hope from what we heard, it is, I understand concerns about cost, absolutely, and there has been a huge discussion within the team as well. It is the best cost that is on offer at the moment until we actually, until prescribers are actually able to offer NHS prescription, which clearly is something we're also working towards. We are actually in discussion, I should say, with NHS, and we have had interest from the government to see our findings. So it is moving in the kind of way, to see actually that's feasible. Actually, so far, and so far findings are positive. That's also why I'm highlighting the fact that we haven't had any yellow cards, over the 800 patients. There weren't any serious adverse effects so far. And hopefully that is also sufficient for the government to see, actually cannabis in the UK can be prescribed, and as it is in many other countries, obviously with keeping tabs on it, registering it, really doing the research on it, understanding patient, understanding dosage, but absolutely it's really our aim is also, that's why I said the project is, the aim is for 2 years, by which time we hope to have enough data so that NHS prescribers feel confident to prescribe. So that's one of the aims overall as well.
Yeah, someone said having interest from the government is awesome. And different question. So based on what you guys are currently studying, is there any scope to research concentrates, especially for cancer prevention for high risk? Are there other formulations or consumption methods, I guess, that you guys will research?
This is a very good point. Not at this stage, because as you can see, we've kind of stuck with it. Well, not too much. PTSD is also, or Tourette's and so on. There's the evidence base is still not huge. We haven't got the plans at the moment. We haven't got the facilities at this moment, but it very much depends on how things develop also within the cannabis clinics and the prescribers here in the country.
Right.
If there is a huge jump, if things are starting, we're absolutely open. There is something else in the pipeline, but I'm not sure if I'm allowed to discuss this now, but you will see it.
Fair enough. 2 questions about things that might be in the pipeline that you could possibly comment on. Number 1 is, will there be a similar study coming out for psychedelics in a working group? And is there any interest in autism research? So maybe you could comment on either one.
Yeah, absolutely. First, let's stick with cannabis. The autism, absolutely. I mean, it's a challenging thing, because so one of the other things which I haven't mentioned, so for example, myself and the team, we looked at the international databases. There are big scale databases, Health Canada, Minnesota. There are thousands of patients using medical cannabis and have been for years, especially US and Canada. And autism actually does come up, and ADHD does come up, and so on. So there's absolutely something there, and there are some initial studies actually already as well. So yeah, absolutely. That's, as I said, we are keen to widen the applications as soon as we can. And the in relation to psychedelics, yes, there's something in the pipeline. Also, I think I'm not allowed to discuss much, but there's absolutely something in the pipeline, and we are very much hoping this will happen. Of course, we have to also take into account that medical cannabis here in this country is legal. We can do this study because that's how it is. for medical psychedelics at this stage is extremely challenging, and you really have to go through. It has to be in a very different approach, but the aim is there.
Yeah. I missed one question that is another condition possibly being researched, which is about bipolar and manic episodes from THC consumption. Is that something that there is research going on and that you guys are doing?
So that people have these episodes after THC consumption, or to treat that?
His question, maybe Andy can clarify, but he says, is bipolar and manic episodes from THC consumption being specifically researched? We'll see if he.
Yeah, I mean,
I don't know. I don't want to speak for him.
We have in terms of this is not bipolar, but the kind of still exclusion criteria which we have, which is schizophrenia and psychosis, we do have as exclusion criteria at the moment, even though there is quite a bit of initial research now, even randomized controlled trials using CBD to help psychosis and schizophrenia, but these are still very, very challenging areas. But that doesn't mean that we wouldn't want to do it in the future. But as I mentioned, we stuck with the evidence ones first.
All right. And then on the patient side, a question about access. So will patients be able to continue to access medical cannabis privately if at that point it becomes widely available on the NHS and they wish to remain privately prescribed?
Yeah, I guess so. I mean, NHS is different to private, though. No, and
Yeah.
NHS, our aim is, and let's see how, loads is happening at the moment. I think once we've kind of behind COVID and behind Brexit, I think hopefully there's loads of positive things that can happen in the medical cannabis space, and of course private prescription are always available. And from what I hear, also the price has been going down a bit, which obviously is a positive thing for everybody involved. But it is still more than many people can afford, from what I hear from patients.
And then on the note of funding and access, a question about how much of the allocation of funds for research influences the data collected on patients. So that's more on the research side.
So, I mean, is this meant how we're influenced by industry kind of thing?
To an extent, yeah. Like how does the funding that you have or have raised, how does that allocation then influence what data might be collected, could possibly collected?
So we as I mentioned, our licensed producers, of which we have a consortium, they do not influence the data collection per se. This is really the drug science team. Obviously, we are employed, and that's what the kind of their contributions lead to, as well as they actually contribute the medical cannabis products.
Right.
But they do not influence the data, and they are not involved in writing the reports or writing publications or anything. That's absolutely clear no from all of us.
Very scientific driven. And I think Abbie added here, the scientific oversight board decided this about like the data being collected. And then a follow-up question from Linda. Do you have a data-driven research project yet that takes into account the role of minor cannabinoids? So for example, using AI to analyze correlations in the response of patients to fluctuations in minor cannabinoids or terpenes in the formulation, which could help drive evidence-led prescribing without separately extracting and prescribing each component.
No, this is fascinating, and I have to unfortunately say no, but we are really working together with the companies to actually also give us absolutely clear outlines of what minor cannabinoids are in each of their products and so on. So, but we have not actually done the research, and I do think it's beyond the scope of the project at this stage to look into it, but absolutely something for the future. I mean, I know the team is absolutely aware of that. Cannabis is not equal to cannabis, and there's just so many different compounds that are potentially active and that need to be researched, but we're not quite there yet.
Right. Seems like there's a lot to do and explore with this plant in the research. I think the final question, and if anyone does have further questions, you will have Anne's email. You can reach out to her directly or to me, and I can pass it on. So the final question is, what happens if Project 2021 ends and then private prices go up? again, more on the patient side of prices?
I mean, this is one of our concerns. I very much hope, and I don't think this will happen because the prices have been reducing. There are more and more medical cannabis clinics coming to the UK, and we're all working towards really also not just, as I say, the patient access, but also really the policy changes and changes that ensure ease of the changes in regulation, maybe that ensure easier importations regulations for the companies. I mean, it's not just, I should also say, it's not just us doing the work, obviously. It's a huge consortium of researchers, academics, physicians, as prescribers, as well as obviously industry, who have a huge interest in moving the cannabis space forward. And just as an example, Professor Mike Barnes, who we're working with as well, is just developing basically a council for the industry just now, basically, in order to move things forward and to ensure that this situation is not going to happen.
Right. Well, hopefully there's some people here that do reach out and can lend a helping hand in some of the questions that have been asked. I think on behalf of everyone, we can say a huge, huge thank you. This was a fascinating presentation and really great to kind of see where the research is and what left. There's still more to do. So yes, claps from everyone I see, and thank you very much. Yeah, I will now invite the rest of the panelists to come back online with their videos on, and we can get into a panel discussion as well. Yeah, I'm just seeing if there's further comments. All right. So the panel, we were also supposed to have Dr. Rebecca Moore, but she has something come up tonight that she's unable to make it. So hopefully we can get her back on for another fascinating conversation. But we have some incredible panelists here. So I'm really excited to just dive in. And Abbie, you are first on my screen. So I'm gonna pass it to you for a quick introduction about who you are, what you do. Yeah, sure. Tell us a bit about yourself, please.
Hi, thank you for having me, and well done, Anne. That was great. I always love hearing you speak and sharing the latest research of drug science. I'm Abbie Hughes. I am the Chair and Outreach Director at PLEA, Patient-Led Engagement for Access. We are a community interest company, and we put patient-led in the name because we are patient-led, and we think that's really important. There is no face of medicine without the patients, and we're thankful that we get to work with so many great colleagues who realise that as well and want to include us in all of this. My background is NHS operational management. By accident, fell into that because I was a patient and wanted to make change. Ironically, got made redundant when I was sick, waiting for surgery, and that's when PLEA came about. We're super excited that we have so many great people on our advisory board, including Dr. Callie Seaman, who's speaking with us tonight, Professor David Nutt as well from Drug Science. And we also have our patient working group. We've just recruited our 25th member today. We have some audience members here from our patient working group. We have audience members who have applied for our patient working group who are waiting to go through that process. And we're just really grateful that we get to challenge these inequalities. A lot of us do have prescriptions, but it costs a huge amount of money. It's not sustainable for many. Some patients are choosing between eating and medicating, and that's just not right. So what we do at PLEA is sort of be that support network to help people navigate these healthcare systems and to again challenge the stigma, challenge the lack of education, and really put things out there. A big thing we did last November was the Medical Cannabis Awareness Week. We had over 1,500 individual attendees come to 15 events across a week. They're all available on our website, pleacommunity.org.uk, as will this talk be actually, hopefully, by the time it's been uploaded. And yeah, thank you so much for having us. I look forward to delving into a bit of conversation with you all.
Amazing, thank you. I'm gonna pass it over to Callie, since we mentioned her name already. And if you could do the same, give us a brief background, a bit about yourself.
Right, well, I am Callie Seaman, also known as Dr. Callie Seaman, not a medicinal doctor. I come from the hydroponic industry and have worked with a number of licensed cultivation facilities in the UK and internationally on looking at increasing cannabinoid content within different crops through crop stressing, through fertilization regime. But not only that, I'm a patient. I suffer with epilepsy and was diagnosed at the age of 15. I was lucky enough to have a father who was very open-minded back in the 90s and introduced me to cannabis then. Throughout the years, I've kept that very quiet, but now I've joined a number of support networks, such as MedCan support for parents with children with factory epilepsy, and helping support them through and navigate the way through their actual journey through medicinal cannabis, and just understanding that whole process. Hannah Deacon's in this talk as well. I work with her about that, and Matt Hughes, who isn't here today. I'm also part of CPASS, which is that helps support nurses as well and help to educate those, just on the advisory board there, and just recently joined Abbie on the advisory board for PLEA. So very much hands-on, want to give that real kind of real world kind of education, that it's not just about what's in the book, what's the textbook, what actually happens to patients and how that journey is. A lot of people don't even realize that medicinal cannabis is legal and how to obtain it. The amount of DMs are asking me, so how do I get this prescription? So this is what this is all about. And thank you again for the talk and what drug science is doing, and everybody here today.
Amazing, thank you. It's so great to see how interconnected everything is. I was going to pass it on to Hannah, and then you mentioned CPASS, and that's where Sophie is from as well. So I'll pass it on to Hannah, and then Sophie, when Hannah's done, we can kick off with an introduction from yourself as well, please.
Thank you, Jessica, and thank you so much for inviting me tonight. I've loved listening to Anne as always, and thanks for all your questions. It's really interesting. So I started my sort of journey into medicinal cannabis because of my son, who has refractory epilepsy. And I won't go into the long story of that, but we were very lucky to have worked with End Our Pain, the lobby group on medicinal cannabis. And in June 18, we received a Schedule 1 license, so our doctors could prescribe medicinal cannabis on the NHS, and Alfie now has an NHS prescription of Bedrolite and has done very, very well on it for long periods of seizure freedom. When the law changed, I was, very happy and proud to have been part of that movement. There were other families involved, and it was a great day. And then it was very quick that we realised that actually there was huge problems, and I've carried on campaigning because of that, because it should be fair, and it's not fair at the moment. I now also work as a director of the Medical Cannabis Clinician Society, because I feel very passionate about education, because that's one thing that is a real problem within the medical sector is ignorance, basically, and lack of understanding, and that's something I'm very passionate about helping to deliver. As Callie said, I also help support MedCan on a peripheral basis, because it's really important. One thing I never had is any support or anyone to talk to when I went to Holland in 2017. And I think having that support group is really, really important to share information and just feel like you're not the only person in the world who has a child with epilepsy, which is how I felt in 2017. And then also, finally, I run a consultancy company called Maple Tree with Professor Mike Barnes and my other partners, Peter and Will. And we are trying to help create a patient-focused sector. As far as I'm concerned, that's one thing that I feel is missing at the moment. And I feel very, very passionate that I want to work with companies and organisations and partners who see the most important person in the whole circle of a commercial business is the patient, and that's really, really important to me. And also I was a full-time carer for 7 years, and I needed a job, and I thought, well, I'll do this because I love it and I'm passionate, and as far as I'm concerned, it's a vocation, it's not a job. And I'm very, very, very lucky every day to be working in the sector with so many amazing people, but it's not good enough at the moment, and that's what I'm trying to help be better.
Thank you, Hannah. I think a lot of us are also really happy that you're doing the work that you're doing, because it's so needed. And like I said at the beginning, this is one of the reasons Jasmine and I felt so strongly about hosting an event like this, because the number of times during my PhD whilst collecting data, I have seen this tension between industry and patients and what that looks like. I mean, anthropologically for me, it's fascinating, but from a practical perspective, what does that look like? It's pretty different. So I think we'll get into some of that a bit later, but passing it over to you, Sophie.
Thank you. Thank you for inviting me to be part of this. So speaking alongside some very busy and impressive women. So thank you. My background is that I currently am the clinical lead at CPASS. I'm a registered nurse. My background is A&E and then intensive care. I left COVID frontline end of last year for a number of reasons, and was lucky enough to be asked to be the clinic nurse at entOURage Clinic. So I have the pleasure of working with patients on a daily basis with managing their cannabis medicines. My introduction to cannabis was through advocacy, and that my partner was diagnosed with Crohn's disease in 2010, and found cannabis incredibly useful in managing his symptoms. And it was just I think I say this over and over again, I think that there is very few experiences that are as distressing as seeing someone that you love in pain and not being able to do anything about it, and finding something that helped. It didn't matter. The legality of it needed to be addressed, and that it was helping a lot of people. And I think I'm certain I'm not alone in that feeling. So thank you. So that's where I'm.
Amazing, thank you. So to give everyone a really good picture for those who are in the UK or those who are outside, it seems like there's some people here from Canada, Israel, the US, and elsewhere. I kind of just want to share everyone's current experience with medical cannabis in the UK. So whatever perspective that means for you, if it's like, what does your day-to-day look like, and what are the current exciting things going on, and what are the current challenges going on? Let's just picture the UK cannabis market in the best way possible, because we have people from the patient side, the research side, the medical side. Yeah, so Sophie, you're still on that screen, so let's go back to you.
I'm so sorry, I was looking at pros and cons, or just the daily workings of what I do now?
Yeah, I would say pros and cons of the current, the medical market, and how that, like, what is your daily experience of that?
For myself, there's a massive pro in there being like, it's a pleasure to really get the opportunity to take care of patients on this journey. People come from different backgrounds. You have two groups of patients. Some of them are incredibly knowledgeable, and they've been using cannabis for literally decades before they've had to sort of enter this system that's quite hierarchical and returning back into a medical format of how to get their medication. And that's a pleasure to talk to them, and to sort of for some patients, it's the first time they've re-engaged with medical professionals for, again, decades, having felt that previous to that they had not been listened to or taken seriously or managed correctly. The cons are that, obviously, for me, it's very evident that patients who there are patients who are exactly as I think someone said earlier, that Callie said earlier, there's a lot of patients who are not even aware this is an option for them. And I think that's true of frontline nurses and doctors as well, that they have no idea that this is an option for their patients, either through miseducation or just it just not being in their frame of reference for their current situation, especially with COVID, that everyone's sphere of relevance has shrunk very, very, like, it's a very minimal interaction with, also minimal learning. So those are my pros and cons. I really do enjoy my day job. I still work in ITU to retain my frontline nursing skills, and I would miss the NHS if I wasn't part of it in some way. So that's my perspective from where we're at the moment.
Awesome, thank you. let's go over to Abbie so you can shed a bit of light also on that patient experience, because it's interesting to have the compare and the contrast between the medical professionals to the patients.
Yeah, absolutely. Well, it's twofold really. Lots of patients are getting access to their medication through the private sector. They are improving their quality of life. They are then able to do things like come and maybe volunteer a few hours with PLEA here and there, things that they didn't think they'd be able to do, they're now getting up and doing, but that's coming at a great cost to people. Personally, myself, I spend my personal independence payment, my PIP money, all goes on medical cannabis. I had thousands of pounds in savings before, not loads, but you know, I had a few, and now I don't have it. I don't have it because I've tried this medication, I've tried that medication, For me, I now only have to see one doctor versus I lost count after about 20 consultants. I was under pain management, urogynecology, gynecology, rheumatology, cardiology, how many ologies, lots of ologies. And that was unsustainable going. I'm based in Birmingham, and I was going to the hospital in London, Stoke, Stafford, all different hospitals across Birmingham. One day I had 3 hospital appointments across 3 different hospitals. That is just not sustainable for a patient either. And now I see one pain management specialist who understands and keeps in touch with my other ologists. And I don't have to see lots of different specialists. I've been put on watchful wait from gastro, for example, because they're really pleased that I'm on an observational study, which is going to look at not just my pain management and my anxiety, but the impact on my gut and the impact on my sleep and things like that. And I can go back and see them in a year's time and report back. So I'm not having to see as many doctors, and I'm certainly not taking as many medications. At PLEA, we get queries pretty much every single day around help, I want to access medication, or help, I can't afford private medication, how can I get it on the NHS? So we put together some resources around this because there just isn't anything available for patients. There things like, you know, how does this all work? How much does it cost? Where do you get cannabis from? So we have like a clinic directory and things like that. And these were put together by our working group. These were resources we wish we had had access to as patients. So yeah, it is strange because most doctors, once you have this conversation, they're receptive to talk about it, but many patients don't want to talk to their doctors about it. They're afraid, even if it is a private prescription for them, even if it's a prescribed medication, many doctors and clinicians are still afraid. So patients are then afraid. We have one of the resources we made is managing stigma and talking to your doctor about all of this, because they could be just as frightened as the patients. And I think this is a big gap in education on both parts, which I think that's where I feel everything's at right now. We're getting there. There's lots more education, but it's just not enough. People don't have an understanding yet. It's already been pointed out. Some clinicians do not even know this is an option. Patients don't know it's an option. So the more patients can share their story, I've realised I haven't even said I have Ehlers-Danlos syndrome, POTS, fibromyalgia. I'm also autistic and have ADHD, amongst a bunch of other things. Hence, I see so many ologists. And it is good to be able to now just rely on medical cannabis and not to be, ironically, off my face on drugs, on various opiates and whatever the hell else I was doing when I was a manager in the NHS. I don't know how I did that, but yeah.
Thanks for sharing that experience. I think it really puts into perspective what some of the daily challenges are. I mean, even emotionally, financially, all of it together. And I'm going to pass it over to Hannah, because similarly, I'm sure you've had an experience that you can share, and you've been in the spotlight in the news many a times. And I know even Callie said earlier, you've been such an inspiration. And so if you can just talk about your current experience and maybe even how it's changed a bit when reform has happened, and perhaps what you think still needs to happen if your current experience with medical cannabis is not the ideal situation it might be.
Yeah, thank you. My situation is very positive. in the sense that my son has an NHS prescription that I can go to my pharmacy and collect every month that is funded. I had to fight very hard for that. I had to prove that it worked. I know that I was also lucky in the right place at the right time, working with the right people. And I know that, you know, that's why I do what I do, because I'm very, very grateful for that. But I also know that it saved my son's life in the sense that he had no quality of life. He was having hundreds of seizures in a clustering of seizures every week. I was taking him in an ambulance, or my partner was into hospital at night, because they always start at night. They never started during the day. So we would always be woken in the middle of the night, which caused severe anxiety and PTSD type symptoms in me and my partner. At the time, our daughter was 3 as well. Our daughter Annie, who's Alfie's younger sister, was 3. So it was incredibly difficult, and our quality of life was so poor. But most importantly, so was Alfie's. Alfie's quality of life was either him having lots and lots of seizures or coming home. He was, as Abbie alluded to, my son was given massive doses of methylprednisolone, massive doses of phenobarbital, midazolam, rescue meds. He was off his face. He would come home completely off his face, beating me up, hitting me, punching me. My partner's 6'3" and plays rugby. You know, he's a big lad. And I thought, Alfie's going to be that size one day and he's going to kill me. You know, I really thought that. And I want to always be able to be a mother to my child. I don't want to be that mother who has to sadly put their child into care when they're a teenager. So that's what drove me to use cannabis with Alfie, because we were desperate and we needed to improve our quality of life. And it wasn't easy. I had lots of pushback from NHS doctors that were involved in Alfie's care. But I did it anyway, because I wanted to be able to know that if Alfie did pass away, that I'd done everything in my power as his mother to save him. And like Sophie says, it's the most horrendously upsetting experience to watch anyone you love, but especially a child, go through something so awful. So, you know, that was, to, you know, circle it round, that's the life that we were living, and it was awful. And now Alfie goes long periods of time with no seizures. He's engaging at school, he's learning. His development has gone off the scale. He's catching up with his numbers, his words, his interaction with his peers. It's just an amazing sight to see, but it also is what motivates me to do better for everyone else, because it's not fair that Alfie has that benefit and no other child other than 2 very lucky ones has an NHS prescription. With regard to paediatric access, we've actually gone backwards, hurtling backwards in the last 3 years, to be honest. We currently now only have 1 paediatric neurologist prescribing at 1 clinic, and he, I believe, is very, very busy and probably doesn't want to take on the whole country of paediatric epilepsy. There were 2 other paediatric, one a neurologist, one a consultant prescribing, who have both been put in a position where they cannot continue to prescribe. So we have a very, very worrying situation for children at the moment, where there are no prescribers, and the NHS, we know through the BPNA guidance, the NHS are not going to open up for children anytime soon unless we continue to lobby as we are, and try and do everything we can to help that change. But basically at the moment, prescribers for children will not come forward through fear of losing their careers or fear of being reported to the GMC, etc., etc. And that is a scandal as far as I'm concerned, when there is good evidence for children to be prescribed, and it should be funded. And actually the children that are paying the private prescriptions at the moment, their families are paying, you know, if the ones that started at the beginning in 2019 got into this trap whereby the only product that was available was Bedrolite, which is extremely expensive. Their children are all doing very well on them, and they can't and should not have to be forced to move to another product that's available. It's great for naive patients that there's lots of choice now, but those patients are stuck on a product that is very expensive privately, up to £2,000 a month for some who have got big doses, and they're having to fundraise or sell their homes or ask their mums for loans, or, you know, whatever. It's absolutely disgraceful that those families who are already vulnerable are being put in positions like that. So it is very upsetting. It's very difficult. It makes me very sad, and I think that a lot more can be done with government, i.e. with them funding research, with them supporting the development of the sector. It's completely all over the place at the moment. And so yeah, that's my reality. That mine is I'm very, very lucky, and that's why I work really hard every day to try and do my bit to make it better.
Yeah, it's really crazy to me at times, because I'm currently in the US, I'm in Colorado, but I know, for example, in Delaware, a law passed for pediatrics under Riley Meadler, and it was her fight and her battle, and then it was just the stories that had to be told and the evidence and things like that. And I really hope that the UK doesn't continue to move back in time, that we move forward in time. It's just, it's all, the paradoxes are endless.
Yeah, I think what makes me very angry, just finally on that point, is that we, or doctors in this country, should look at this as about harm reduction. Because actually these families are, and we know that through MedCan, these families are going to use cannabis with their children, whether it's private or NHS or legal or not legal. And what's happening at the moment is families are being pushed to the black market, where they're buying products where, you know, they don't know what's in it. And for some adults that might be fine, but for children with serious neurological conditions, that is not okay. And I find it flabbergasting that doctors are happy to block it, and other, you know, we know there are organisations pushing for there must be randomised controlled trials before any paediatric access. All that's doing is putting very vulnerable people in a position of more vulnerability. Actually, what we need to do is accept it's going to happen. How can doctors keep these people safe and give them clinical advice, and do the research alongside, as Anne said earlier? That's very important, but we need to give access to children now and learn as we go forward. Yeah.
On that note, I'm gonna open it up. Callie, I'll point it to you next, because I think we haven't heard from you yet. What have the tools been that have been really successful in, maybe it's pushing for a harm reduction policy reform, or tools that have been successful in destigmatizing medical cannabis, whether it's for the patient or for the prescriber or a medical professional? Just interested to hear what has worked and what hasn't worked. And then obviously please shed light on your current reality and your experiences as well, in addition to that.
So I think everybody that's on this call have really played their part in the education and removing of that stigma. I knew things were changing when I had teachers started to ask me more and more about it. Those kinds of people who I would hide this from. This was I spent many, many years hiding what I did and was actually quite ashamed of it. I got my first legal prescription at the beginning of this year, and I no longer feel like a criminal. That has been removed, and that stress has been completely removed from me. Now, the quality of the product that I actually got was, if anybody's actually seen my videos, my George and I videos, and I did the whole unboxing of it, was shocking. I was very disappointed. It was all pre-ground, and there's still a lot needs doing in this country to actually change this. And a GP wouldn't know the difference between what was good quality and what was poor quality. What also was quite disappointing with it was actually the lack of information that came with it. All that was reported was the THC and CBD content, nothing else, absolutely nothing else. No terpenes, no minor cannabinoids. So there's a lot more education there sort of needed. So it's happening, things are changing here, certainly. And as I say, these patient-led groups, I feel, is where the real success has been, where the real life experience have been communicated, not something from a book, not something from a study or a peer-reviewed journal that the patient has no understanding of or real interest in, because they don't really care for what methodology was used, or was it methanol or ethanol that was used to extract, and was it 4 minutes or was it overnight? They don't care. They want to know, does this work and how much do I use? That is the reality of it. My day-to-day kind of, some of the kind of barriers that I'm sort of hitting with the day-to-day is I have not come across one domestic supply, legal domestic supply in this country, which is coming through and being prescribed in these private clinics. Everything is being imported. And then we've got the number of hurdles that are now coming to actually get those imports. My prescription came all the way from Australia, why is there a product coming all the way from Australia when it should be available in this country? There's a whole economy to be stimulated there. I think there's a lot really needs doing to move this forwards, but I just want to sort of thank everybody, as I say, on this con. There's many names that I've seen here that have moved this forward and helped with the education, and actually really given people like myself the strength and the courage to speak openly about my experience, and inspired others to do so much more.
Yeah, I love your videos because I think they are so informative and definitely inspiring to a number of people. It really is crazy that your medication came from Australia. So, I mean, just in terms of the environmental impact of that, it's insane. But why it can't come from the UK is another question when we have GW being one of the largest producers in the world. On that note, before I go off on a tangent, how can we foster better relationships within the supply chain, whether that is the UK domestic supply chain or some more of like the global supply chain? What do you think needs to be done in order for patients to have the supply that they need, for these frustrations to be settled a bit? And ultimately, how can people on this call within our communities really support those relationships and the supply chain to move more fluidly rather than in a disconnected way or fragmented way? Callie, feel free to comment on that one first.
Well, there's many steps. We need to stop importing. First for me is getting this domestic supply to cut down the air miles on it. We need more transparency of the actual product that's being supplied. So how it is grown, is it grown under lights? Is it grown in soil? Methods of extraction. There needs to be as a whole bigger transparency of the industry and a lot more information given. I think we could do with cutting out some of the middlemen as well. I think having a domestic supply would do that, so that it is the actual farms themselves that are dealing directly with the pharmacies, to really cut out those people who are taking a slice of the cake that are not really needed, that could help to reduce the cost of this as well.
So on that note, that's one perspective. If we bring it, I want to go back to Sophie, from the prescriber, the medical professional perspective. What do you think needs to happen in order for medical professionals to feel like they can prescribe medical cannabis, or for the industry to, how can the industry interact with medical professionals more or less in order for some of these steps to be removed, as Callie has suggested, for example?
I mean, my response to that would be sort of there's different layers of education that need to happen and input that needs to happen. There's education that needs to happen for GPs and nurses who have no idea about cannabis being an option, and to get them having the right conversation with their patients, and therefore the patients being able to to sort of demonstrate the demand for cannabis medicines. The second part of that is that the doctors who are already prescribing, I think it has a lot of weight for those doctors to request exactly what Callie is talking about from the producers, which is saying, you know, these are the things that we keep being educated that it's more than THC and CBD. There are the minor cannabinoids, terpenes, flavonoids, that we keep being told about this terminology and all these different parts of the plant that are actually helpful for our patients. And from my experience, doctors who are actually, as soon as you get them engaged in the chemistry of it, they actually become really fascinated by it. And as soon as they get fascinated by it, that's when they start to that's where there sort of seems to be a hurdle, because you're like, they have a real thirst for understanding how it works. And I think that if the doctors who are currently prescribing put more of pressure on producers to provide that more in-depth information, because they need it in order to prescribe the right medication for that patient, then I think that will have an impact on, or I hope that it would have an impact on what kind of information is provided, because I think that's key. I think that's, and I think other people agree with me on that. In terms of the idea of how we get more people to prescribe, the reality is that, or my understanding of the reality is that medicine is very hierarchical. How doctors are trained is very hierarchical, and it requires older doctors to take that leap forward and say, you know, I've worked in medicine or I've worked in my area for pain, oncology, neurology for 20, 30 years. I have tried everything. I have seen thousands of patients, and this is actually having an effect much faster, much safer, much more holistically than I've ever seen anything else work. I'm excited by that. And that actually will have a huge impact, because the doctors who are training to become specialists or to get to that level, their GMC number is invaluable to them. It's invaluable to lots of people. And I remember when I was advocating as part of the United Patients Alliance, and I was training to be a nurse, I was very, very passionate about getting cannabis, like getting access to cannabis. But I was also simultaneously very aware of how much of an impact being very visible, very vocal may have on my ability to reach my goal of being a nurse. And I got told by an advocate then that I would have more of an impact overall if I continue to train as a nurse. And that is true, and doctors are very aware of that. Doctors training to get to that specialist place where their opinion has more weight are afraid of not being able to get there, and that actually getting involved in cannabis might prevent them from doing that. And you know, I'm very passionate about it. I think it's fascinating. I think it's got a huge amount of potential medically, and I still return to ITU. I tell my colleagues what I do, and there's still like this, there's still this stigma attached. There's still this sniggering, like, oh, is that what you do? You know, can I get some? And you're like, actually, yes, you just have to go through a very like arduous path to get there. But it's trying to remove that fear and the joking. Take this seriously. Or like this, if you actually could see the data, see the potential, see the effects it has on patients directly, and I'm talking nurses and doctors here, you would start to take it way more seriously. And I think, you know, we say it over and over again, that education is the way to reach those people, and it really is. And for nursing education specifically, that it was always key to have patients as part of that education. When I was training, that we would have the theory, you know, you'd sit there, get told that, so this is how it works, this is how the system works, this is how you treat this, this is how you manage this case. And it's just information coming at you. But as soon as a person stands up and says, and is brave enough to say, you know, I'm in pain like this every day, it impacts my life in this way, and it reframes the conversation from the theory into a real person. And really, you know, doctors and nurses, they're people who care about people. They've entered that profession because they want to help people, and that relationship is key. So that was a very long-winded way of saying that education is key, and that it is a hierarchical system that involves people at the top end stepping forward first. And it's a very brave thing to do that. But if you're supporting doctors in the way the Medical Cannabis Clinician Society is, for example, it gives them the confidence to carry on doing that, and more people will follow them.
Yeah.
Can I jump in here?
Of course, I was going to hope you would.
From the patient's perspective, I totally agree with all of that, Sophie. When I was working in the NHS, I'd be like, oh, Professor Oncologist, have you seen this study about the endocannabinoid system? And I think our language and what we choose to talk about plays a massive part in that. I was in hospital for a week when I had hip preservation surgery, great. And I was very honest about my medication. I spent the first 2 days passing out, unable to take any steps. They weren't letting me out of the hospital until I had walked up a flight of stairs. I've got POTS, and apparently with POTS, your recovery is going to take 10 times longer than a normal person. So I was already expecting this was going to be hard work. Day 3 in hospital, I took my oil and I walked up the stairs. And my physio was like, what? You literally were passing out this morning and now you're walking up some stairs. Huh? And it took me, you know, a good few days more to be able to get out of the hospital. But my point around that is, I started off by talking about cannabis, and they were going, "Oh, get your friends to pass you a spliff through the window, ha ha ha." And I'm like, I don't want a spliff through the window. This is my medication. This is what's making me better. Like, I don't want to get stoned. I just want to be able to walk up the stairs and get on earth out of this hospital. And the next day, when the next shift leader came on, I had a different approach with her. I said, "Oh, do you know about the endocannabinoid system? I had this experience yesterday, and this is why, because I took this oil." And this was before I had a prescription even. And they were so receptive. It was telling a real story, and that is what matters. And I think sharing case studies around not just how my pain is managed, but, oh great, now I can eat, now I can sleep, now I can go for a poo, because that's what humans do. Great. That is a normal thing that we should just be able to talk about. Instead of me going to all these ologists, I can now, I don't have to go through all of that trauma. I can have one thing that helps. And I think when one of the big bottleneck things here is that cannabis isn't treated as a medicine yet, and the government need to treat it as a medicine. They go on about RCTs are the only way, randomized controlled trials are the only way that your medicine can become available. Well, that doesn't work for cannabis. It doesn't work. There's too many compounds. It's too complex. I, as someone with all of these different ailments or conditions, wouldn't be eligible for a lot of studies, because you'd have to have just this, and it would look at just this aspect, and that's not how it works. We've just had these vaccines rolled out with no randomized controlled trials. So let's take this opportunity, and I think a campaign around looking at education, looking at research that isn't RCTs is going to be the next step. That's going to be how we break the bottleneck and widen it and say, hey, hang on a minute, we need to take things like Project 2021 and these are the medical cannabis registries seriously, and they need to be patient reported outcomes, not just RCTs with 20 odd people looking at one symptom. It needs to be full on patient reported outcomes about how we are changing the way we live our lives, because our quality of life is much better.
I think especially for cannabis, there's something to be said about the social science background of it, that it doesn't need to be so quantitative, but it could very much be qualitative when we hear these anecdotal stories. And as an anthropologist, I always struggle to be in this hierarchy of science, and it's very much at the bottom, because what I do is I retell stories, and being in the cannabis space, writing my PhD on this, these are the stories that carry the industry, that created the industry, that maintain it, and all of that. And sometimes it seems like the policymakers are less interested in that, when that's really what, as Hannah knows so clearly, like her story, for example, changed the reform process. So Hannah, I will bring it back to you. And if we can think about, in a utopian world in the UK 5 years from now, what would you hope happens in the UK? And then on the flip side, like realistically, where do you think we'll actually be in 5 years from now? And for both, how do we get there?
Okay, I think what the huge issue with the medicinal cannabis as a product is it doesn't fit. It's a botanical. It doesn't fit in the pharmaceutical model. And at the moment, the government don't understand that. At the moment, the hierarchy of the NHS don't understand that. And they are insisting that, cannabinoids in their, in an isolate form need to be RCT'd before they're given to anyone on the NHS. And I think that's a flawed model, because we'll be waiting for hundreds of, if not thousands of years to have any medicines available. And also, as Abbie said, my son is one of 9 boys in the world. There's not even any research into his condition. So they're definitely not going to be RCTs in his condition for cannabis. So, what we have to remember is a lot of symptoms that cannabis is very effective for are chronic and are usually rare as well, especially in the epilepsy side of things. So I would like to see an understanding by government and NICE and the MHRA, it's a long day, that this is a botanical, and create a framework that makes it safe, that invests in research, but that doesn't try to sort of shoehorn it into a pharmaceutical model, because you'll continue to get people either using private sector where it's very expensive and many people are then priced out of obtaining it, or there aren't the prescribers, or you'll continue to push people to the black market. And what we need to do is make patients safe. That's the most important thing. So I hope in the next 5 years that there is a move towards a new framework, like in the Netherlands, like an Office of Medical Cannabis, that recognises this botanical plant as a medicine, as having very favourable outcomes for many chronic illnesses. And that is, you know, as I said, government, you know, are supporting research, because actually that's one thing that they're asking for at the moment. They're saying, oh, there's got to be more research, but actually they're expecting all cannabis companies to pay for that research when this is a plant that can't be patented. The only way you're going to patent something is through a delivery system or something, or a unique profile or a unique way of making the product, which might then remove as much, you know, it being as effective as sort of a basic whole plant product. So we need to have investment from government. We need them to put their money where their mouth is, in the sense of them investing in research and going to universities and looking at how they can support, and, you know, drug science and organisations like that, so how they can support the development of robust research, rather than, you know, I get very angry about the government talking a lot about all the things they've done, especially Matt Hancock, who I've met many times and has told us lots of things that never come true. You know, we need to see them actually commit to the development of this sector, because as Callie says, you know, we are going to need the economy, we're going to need better patient access. I actually believe that we need to have, you know, hemp growing, we need to have sustainable medicinal cannabis growing as high THC licenses in the UK. They are very, 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 very difficult to come across, because the Home Office don't know, I'm afraid, what they're doing at the moment. They're all very frightened and worried about it, and there's no clear pathway. The MHRA, I think, are the same. So that's why an Office of Medical Cannabis, bringing everyone together. I mean, I remember when I met Matt Hancock, I said, why can't we all sit down around a table, all of us, you know, industry, NICE, MHRA, Home Office, can't we just sit around a table and all talk to each other about how we can make things better for everyone? And it's impossible. I mean, even intergovernmental departments don't talk to each other. So you're not going to get anyone from other parties, for example, sitting around a table talking to each other, which I think is really sad, because the most important thing, surely, when you're a government, is about ensuring positive outcome for people, especially ones that are vulnerable in our society. So that's what I'd like to see. I think reality, it's probably going to take longer than that. But I know, you know, as we sit here today with all these people, that there's loads and loads of people in this sector who are really pushing for the right thing to happen. We might not all agree with each other on everything, but I don't think that that should be an issue. I think we're all adults and we should all try and work together as much as we can to make things better for patients ultimately, which is the most important thing, and actually build a more robust economy. Because if you look at the tax income that can be generated off growing and extraction within the UK, it's massive. And we need to consider that after what we've been through in the last 18 months in this country. So that's it.
Yeah, thank you for that. It's a really interesting point to end it on from an economic perspective, which makes me start to think about the hype and the excitement around the CBD market, because you also mentioned like hemp production and things like that. And I see Callie nodding her head, so I'm curious to get your thoughts on that too. How should the development and the growth of the medical market, with the like a patient-focused, patient-driven market, unfold alongside the growth and the boom and the hype of the CBD market? Do they work together? Do they not? Where do we go?
Well, as Hannah said, the problem we've got at the moment in this country is there is no research being funded by the government for cannabis. It just doesn't exist. It's all LP based. So it's very biased data that's coming through. I mean, we've got drug science, luckily, but we haven't got anything that is an independent. I mean, I've tried to apply for funding to do research on cultivation techniques of it, but because it's a medicinal plant, it becomes into it, you can't apply for agricultural funding. So you then look to the medical sector. Well, there's nothing based around cannabis to apply for research to see if you can increase the cannabinoid content within a plant. So where does the research start? If there's no funding available, if there's no funding bodies, how can the research be done that they're so desperately wanting to actually put out there. I mean, a really big thing I want to see removed in this country is I would like to see hemp flower being able to be used. You know, it's such a valuable piece of the plant. There's so much work. Why can we not use it? Why can we not even think about it? It just seems absolutely crazy when this can be done already. That is where it really needs to be. You know, the barriers broke down, and the number of license issued. There are only 2 people in the Home Office actually issuing licenses and going out and doing the inspections of the sites where the cultivation is occurring. So when there's only 2 people doing that, how can this sector go further forward? So we really need, as Hannah said, we need an actual a government, a body itself called the Office of Cannabis to handle everything, because it's an entity to itself.
Yeah, I mean, it's interesting because a number of countries have done that. So it's surprising that the UK hasn't followed suit in that. I mean, a number of reasons could be whether it's lack of resources or whatever it might be, but hopefully the conversation and the dialogue does continue, and with the support and kind of what I said at the beginning, like, it's so great to see that the women, especially in medical cannabis, are so interlinked and connected and supporting each other's projects. And I also just want to be really conscious of everyone's time. I see that we've gone over, and I could just end up in a conversation with all of you for the next few hours. So I want to open it up to questions from the audience as well. If you guys want to type it in the chat box, please feel free. And whilst we do that, if you guys want to do like a quick fire answer to one question of, let's see, my question was going to be, what's one thing in the market that's working, one thing that could change? But I guess quick fire of like, how can you summarize the cannabis market in the UK in 1 to 5 words?
I'll start. It's not 1 to 5 words though. You're gonna have to give me 5 sentences.
Okay, cut you off after 5 words.
Well, all I want to say is I don't go to a diazepam doctor, I don't go to a tramadol doctor, and I don't go to a fentanyl doctor. So why are there medical cannabis doctors and medical cannabis clinics? I think there's real scope here for change to allow something like an endocannabinoidologist, you know, add another ologist to my list, because we need doctors researching the endocannabinoid system, like we have neurologists who look after central nervous system issues and things like that. So that's what I would like to see change. I think it's going to take a lot more than 5 years, but I think that is where we need to be going.
Awesome, thank you. And Sophie?
So is where we would like to see, or is summarizing? It was summarizing, wasn't it? The current, and again, it would have to be, I can't do 5 words, I can just do that. Yeah, I think potential, less than 5 words, potential. There's potential for medical applications across innumerable fields of medicine. There's potential for collaboration, like real collaboration between patients, doctors, and industry. There's an opportunity that we have here that's relatively unique, that we have a brand new industry that's emerging in the UK, that it requires all of those individuals or all of those individual components in order to succeed. And luckily we do have this collaboration and support of each other in different capacities in different groups. So for me, it would be the potential and to aim to work together to utilize that potential to the best of our abilities.
I was going to say the same as Sophie, actually. I was going to say potential as well, as just as Sophie, and well, you know, potential to be reached, and very much agree with what has been said. And just, yeah, wanted to add to the kind of combination of, you know, people who are, or the consortium of people who are here today and who, you know, who are trying to move the industry and the patient access. That has to go hand in hand, obviously, move it forward, the whole cannabis space. And you know, we always have top scientists here in the country, top universities. I mean, there's really no reason why we shouldn't be doing this. We're producing cannabis. So it's there's no reason, apart from certain policies and regulations, that will need to be changed. And again, we're working towards that too, that the UK shouldn't become a leader in medical cannabis and patient access.
Thanks, Anne. I'm happy you jumped back in and added some final words. Callie, over to you, and then Hannah will have you close it off.
I would say we're embryonic at the moment. We're really at the start of this journey. We are decades behind the US, Israel, and it's sometimes embarrassing when I actually speak to others. You must experience it over there, Jessica, that we are so behind here. We're catching up, but there's a lot needs doing. And like all embryos, they do grow, but it's all about what we put into them and what we feed to it. And it's up to us as patients and everybody here to actually try and help this grow in the right manner so that we get a healthy baby and we get a healthy industry, that everybody gets a share of it.
Thanks, Callie. That's a good word. And Hannah, to wrap things up.
Yeah, finally, I completely agree with what everyone said. And I think the one thing that has really sort of, you know, I think for what that's working is that I've met some absolutely amazing people, not just women, some men too, that are helping to develop this sector. And that's amazing. And it sort of gives me a lot of hope. You know, so my word would be hope. I think there's a lot of hope to be had when it comes to the sector. But we have got a long way to go. And what I feel very sad about at the moment is I look at all the commercial companies within this sector, and I think only one of them has a very forward frontal patient advocate. And I think that is brilliant, but it saddens me that there are no real players in the market at the moment who are actually really listening to what patients think or want or need. And that's got to change. And that's what I'm trying to do with Mapletree, to be someone who hopefully businesses will listen to with regard to why it's important that patients are looked after. And actually, that's how you grow your business. It's not rocket science. If you look after the people that you serve, you will make money in the long run. To just overlook those people, to not take their problems seriously, to have gaps in supply, all of those things are unacceptable. And that's one thing that I hope will change. And I think it will change because of the people that are in this sector who are trying to do the right thing. And actually, as Anne said, there's lots of other companies coming through and clinics coming through who will do it better. And I think in the end, you know, we will have a very good, robust sector. And I hope with NHS access, I really, you know, that's the most important thing. But if not, then let's have a really good sector which is full of educated doctors and where patients can all have access, whether that's because LPs provide cheaper or free product for people who can't afford it or whatever. I hope that that improves for patients as well. So that's
Thank you. I wish
to say.
Honestly, I had like a megaphone to just blast this out to everybody, everyone in the cannabis industry. I wish they were on this because all of your words have just, I mean, they're so inspiring and empowering. And I love that it ends on this positive note that although we do have so many frustrating obstacles and frustrations that you guys have pointed out on your daily basis and your experiences, there's still a lot to do and learn. And as Abbie just wrote in the comments, maybe it should be hope. I mean, it's great that we have this that we're able to share and inspire and encourage each other. So thank you all so much. I'm sorry for going over time, but I really appreciate it. I'm so excited to share this with everyone who wasn't on today. And I've had some messages and chats that have already just been so grateful and appreciative of everything that you guys have shared with your insights. So very well done from everyone in the audience, it seems. And we will from an entourage perspective, we will reach out to everyone for our next event. It'll probably be towards the end of May, and hopefully, fingers crossed, things open up and we can all meet in person soon. But yeah, thank you guys so much. I really appreciate it. And it was an incredible conversation.
Thank you. Thank you.
Thank you. Thanks so much
Thank
for
you very much.
inviting us. Thank you.
you
Bye
so
bye, everyone.
much.
Bye.